in December, and are already looking forward to welcoming him back in April, but is also glad right now that he's back in Rwanda with his family. And thank you, Fidel, for presenting at 11 p.m. I'm just going to do a brief introduction for those of you who don't know Fidel. Dr. Rubagumya is a consultant, clinical and radiation oncologist at Rwanda Military Hospital and a senior lecturer at the University of Rwanda. He completed his medical school at the University of Rwanda and clinical oncology residency at Ocean Road Cancer Institute in Tanzania. He's actually just now completing his fellowship at Queen's University and also completing his Master's of Public Health, where Dr. Booth has supervised him and Dr. Hamad. Dr. Rubagumya's research interests are in health services research, exploring the intersection of access and quality of care, health policy, and financial toxicity in cancer care in low and middle income countries. His clinical interests are in head and neck cancers, breast, gynecological, and gastrointestinal cancers. Dr. Rubagumya has actually won almost the full slate of the awards that ASCO has to offer for young investigators, including the long-term international fellowship, also known as the Life Award, the Career Development Award from ASCO. He's published scholarly work in many leading journals, including Lancet Oncology, EMJ Global Health, JCO, Nature, and many others. And it's our pleasure to welcome you back virtually. And thank you, Fidel, for presenting at Global Oncology Rounds.
Thanks a lot, Scott, and it's a pleasure to be back at Queen's, though far away from there physically. And today's talk, I'm going to be focusing on access to cancer medicine, especially in Sub-Saharan Africa, but my experience is in few African countries, but given my interaction with my colleagues on the continent, some of the challenges that I'm going to be sharing with you actually shared across the Sub-Saharan African region. All right, I think I have it now. So it's estimated that from 2020 to 2040, the annual cancer cases in Sub-Saharan Africa is going to increase to 1.4 million, and the mortality will also double to about 1 million. And when you look at the number of cases, I mean, the type of cancers that are driving the mortality in the region, mostly are the ones that most of all of us that are in global oncology know. That's cervix, breast, prostate, lung cancer, and liver cancer, but also esophageal cancer in some countries. As you see on this map, you see that some countries have specific type of cancer that are prevalent and also the leading cause of death in these countries. Of course, cervix and breast are the most common in all countries in Sub-Saharan Africa. But as you can see, for example, lung cancer is the most leading cause of death for cancers in South Africa, but we also have esophageal cancers in Kenya, and actually what is known as the esophageal belt in Sub-Saharan Africa. So there are other, cancers like liver cancer in West Africa that are the leading cause of death among cancers. And this rise in fatality rates are due to many factors. But when you look at it deeper, I would say from my experience, they're usually twofold. One is because of the diagnostic delays, and another is because of the suboptimal access to treatment. When I talk about treatment, is the whole package of cancer treatment, but specifically what I'm going to be talking about are the cancer drugs here. The diagnostic delays usually is also comes in two folds. One is that there are those that are patient-related delays, but also there are those that are health system related. The patient delays usually because of lack of knowledge about the symptoms of cancer, And sometimes they're actually, though we say that they're patient-related, sometimes they're also not patient-related because, for example, if a patient gets to know that they have some symptoms, they go to the hospital, and then we tell them that they go to do such tests and, test A, B, C, because we want to know what is going on. And sometimes they don't have money to actually pay for that. You would say that that is, some of them actually, they go home and they stay without coming because they don't have money for that. When you're going to classify that, sometimes you can say it's patient-related, but actually it's a system-related because of lack of universal health coverage, as we're going to see along the way. And of course, the health system-related can be, lack of personnel, or even the knowledge of the personnel. For example, in Rwanda, the health system is built from the lowest level, which is the health post. And these are usually manned by the nurses who sometimes are also not aware of most of the symptoms of cancer. And they usually delay patient by treating them as if it's infection or any other diseases, and then they delay patients. So these two colleagues of mine looked at the delays in breast cancer presentation and diagnosis at 2 district hospitals in Rwanda. They had a total of 144 patients, and the median total delay for the diagnosis and presentation in the hospital was 15 months. And when they looked at the patient and system delays, they were both 5 months as median. And when they analyzed further, they found that the patient and system delays that was more than 6 months was significantly associated with more advanced stages, as you can imagine. And it's known that patients, as I said, usually they delay into the system because of sometimes underdiagnosis or misdiagnosis of their diseases. I'll give you an example of tuberculosis. We have documented a lot of cases that usually are treated as TB, and actually they're put on a long-term duration of anti-TBs, thinking that these patients have tuberculosis, especially those that have HIV infection. And after a long time of period, they're actually found to have lung cancer that was misdiagnosed in these patients. So they come when they are already advanced stages that we can't actually do a lot of things for these patients. And it has been proven, for example, this study that was done in Asia, in I think it was 6 countries, they looked at the association of the cancer stage and financial toxicity, or the financial, expenditure to for this patient. And it was found that cancer stages was actually accounted for about, I would say 100% of the risk for catastrophic expenditure. So, for example, if you have a patient with stage 3 or stage 4, you know that breast cancer, you know that this patient is going to actually need surgery, need radiation, need chemotherapy, and other treatment. So that's why it's really related to cancer stage is actually related with catastrophic spending for patients, especially for those that are in countries where they don't have universal health coverage. Colleagues of last year, me and other colleagues from different parts of the world were invited to write this commentary in Nature Reviews, looking at the barriers in access to oncology drugs globally. And each author contributed to what they thought were some of the challenges or barriers to access to cancer drugs in their region, from Brazil, from Sub-Saharan Africa, India, Poland, and Malaysia. And we gave different what we thought were barriers in our regions that I'm going to be sharing with you. For the Sub-Saharan Africa, though we share this with other low and middle income countries, the major impediment to access to cancer drugs are mostly the lack of universal health coverage. Universal health coverage is wide in terms of what it entails, But you will find that in some countries in Sub-Saharan Africa, the type of universal health coverage we have actually doesn't cover every, I would say, medical bill or every treatment that patients are getting, and specifically for cancer patients. For example, in Rwanda, we have a type of universal health coverage where patients actually copay 10% of the medical bill. But when you look at the 10% of, for example, radiation for cervix in Rwanda, it's around a total of 3,000 USD. Then the 10%, that is the total cost of the treatment. And the 10% of that is, of course, 300. But 300 for a common Rwandese who is a farmer is a lot of money. Sometimes this is a money that they don't usually get in a whole year. So you find that this type of universal health coverage doesn't really apply when it comes to cancer treatment. Second, there's an inconsistent drug pricing. This is well known, I think, in the global oncology community, that you can be two people going to the same manufacturer and you get totally different prices for the same drug. And this is hindering some of the government to actually procure these drugs through the government system. And they leave this to philanthropies or even private institutions, which will, of course, hide the prices again when they put a lot of a big cap on the costing. Again, there's variation, of course, in cost between the private and public health systems. And if the drugs are not available in the public system, the private will have the prices for drugs high. And sometimes in some of our countries, there's really no, or there's limited regulatory system to oversee some of these private practices. And of course, the patients are the ones that are going to be bearing some of this burden. Another is the limited quality monitoring of generic medicine. Most of our drugs that we are using in cancer care, actually, we get them from, I'd say, 90% of them come from Asian countries, most especially India and Bangladesh. And these drugs come in without checking the quality. Some countries don't even have the capacity, actually, all the, I would say, resources to monitor the quality of these medicines. And sometimes you don't know whether you're giving a patient the actual ingredient that is supposed to be in the drug. Another is the frequent drug shortages, even for the governments that are able to put the cancer drugs on their what we call essential medicine list, which we're going to talk about. Sometimes there's a frequent stockouts that patients are forced to actually, go to the private pharmacies to buy drugs, yet they're supposed to be on the national formulary. For the drugs that are new and, of course, with greatest benefit, sometimes they're also delayed to be approved, even when we know that these are drugs that can change patients' survival. So one of the solutions that the global community has suggested so that we have good access to cancer drugs is having a national essential medicine list. And this is modeled from the WHO essential medicine list. And currently, there's evidence that shows that most LMICs actually have national essential medicine lists that include cancer drugs. But as we're going to see, having a national essential medicine list alone does not really equate to the availability of these drugs at the point of care where we see patients in our clinics. So the reason why availability or having drugs on the national essential medicine list is not necessarily enough, it's because of many other factors or challenges, and this includes inefficiencies in procurement and supply chain. And as I said, there's a frequent drug stockouts, and when there's frequent drug stockouts in the public system, this pushes patients to actually go to private institutions or pharmacies to buy them, and they have to pay a lot of money out of their pocket. So colleagues of mine looked at access and affordability of the drugs, the cancer drugs that are on a WHO essential medicine list in 3 Eastern African countries, that is Kenya, Rwanda, and Uganda. And they compared the drugs that are on the national EML versus those that are suggested by WHO. And for when they looked for on that, the Kenya had about 93% of the drugs that are on 2019 WHO essential medicine list, while Uganda and Rwanda, I would say Uganda had about 71% for the 2016 national essential medicine list of Uganda when you compare it to 2019 of the WHO, and Rwanda had 41% when you compared the Rwanda National Essential Medicine list of 2015 and those of 2019 for the WHO. As you can see, even these countries, especially, for example, Uganda and Rwanda, they still had the old essential medicine list. So even updating the list, because we have written these lists, updated them, but eventually they don't really translate into the clinical care. So sometimes we don't even update them because we know that they're not going to be implemented. And when they looked at some of the drugs that are not put on this national essential medicine list, some of them cover liver cancer, stomach cancer, esophageal cancer, and these are the cancers that are actually common in some of these regions. For example, these drugs that are very common and important in prostate cancer, especially for metastatic diseases, which is common in our region, they are not actually affordable through the government procurement system. That is, for example, picalutamide, abiraterone, that are very needed in advanced cancers. Same with targeted therapy such as trastuzumab, rituximab, imatinib. These are drugs that we know that are very beneficial, but very unaffordable through the government purchasing system. And this pushes patients to actually buy out of pocket. And it's really unaffordable for many African patients. Dr. Booth and colleagues looked at this issue again in terms of availability of cancer drugs globally. And when they asked oncologists to actually rate cancer drugs, the top 20 cancer drugs and their availability in their countries or in their system, for those that come from LMICs, they say that these drugs were available at 9 to 54%. When you compare this to other regions like upper middle income countries and HICs, as you can see, like for example, in HICs, about 68 to 94% are always available. And these are drugs that local oncologists deem to be very essential. So even availability, as I said, is issue. And when you're looking at access, we are looking at affordability and also the availability of the drugs for the patients. So with this, and of course, having in mind that most of cancer patients in this region are very poor. For example, in 2018, 2019, data shows that there were about 41% of the population in Sub-Saharan Africa lived below the national poverty line. So when you combine this poverty and the lack of these drugs in the public health system, it pushes even these poor individuals into economic catastrophe when they're trying to extend their lives when they're faced with cancer diagnosis. And as I said earlier, research has shown that having NML does not really reflect drug availability at the point of service. So when they're not there through the public health system or covered through the universal health coverage, sometimes these regimens are really not affordable to patients, and they force most of patients to actually sell their items. Sometimes they sell their houses. And as we're going to see from the data that we haven't published this data, but we asked Rwandese patients, for those that have breast cancer, colon cancer, cervix, and lymphomas, and try to go and see what is the level of financial toxicity in Rwanda among the top 5 cancers. So when we ask them about whether they have sold any property as a last resort for to fund their cancer treatment, for example, selling land, selling house or livestock, 44% of them, a total of about 250, said that they actually sold properties as a last resort to, fund their cancer care. And when we asked about whether they borrowed loans that were subject to interest from friends or relatives, 16 of them actually borrowed loans for the cancer care. And then others asked charity from the public to fund their treatment. So as you can see, this is a very huge issues for cancer patients when there's really no universal health coverage. It's not only access to availability of the drugs or affordability of the drugs, but this is actually compounded by other factors. And this is, so for example, one is, the usual complexity of cancer care that we all know. If a patient has stage 3 or stage 4 breast cancer, this patient, for example, stage 3, will need other type of treatment, surgery, radiation, and later on chemotherapy. But that comes even after a long journey of diagnosis and testing and all this. And these all take a lot of money. And in addition to that, for countries like Rwanda, where there's, for example, only one center that has radiation capacity, patients have to travel long distances to actually go to the cancer centers. And this is an additional cost for transportation, accommodation. And of course, some of these patients coming from far, they stop working. For example, if a patient comes to Kigali from the west of the country, they have to come for radiation. They will stay in Kigali for 30 days for the treatment. And that is the 30 days having accommodation that you have to pay if you don't have a relative in Kigali. And as you can see, there's a lot of other added cost. And for example, the universal health coverage in Rwanda, what we call the community-based health insurance, does not really cover chemotherapy per se, but it does cover surgery and radiation. But as I said, even 10% is not affordable for many. So in this commentary, we share what we think are the possible solution, of course, if people put together efforts. One is, of course, having a real universal health coverage. When I mean real, is that even the 10% copay sometimes is not really affordable to many patients. Well, another is participating in clinical trials. As we know, we are still lagging behind in terms of contributing to the global clinical trials. And even the trials that we are participating in actually are not relevant to the clinical burden of cancers that we see in our regions. But we all know that clinical trial participation is one way to actually get access to drugs, especially the novel drugs. Another, of course, is having pharma availing drugs in Sub-Saharan Africa. We know that for a long time, pharma has said that, of course, because of the low buying capacity, that Africa or Sub-Saharan Africa is not a profitable region. But I think this is a time that the global community has to push pharma that so that they don't look at the profitability only, but also look at the benefit of all these drugs. Another route that I think actually has helped some patients, especially for patients with CML, they have patients with CML, especially in Rwanda, have been benefiting from donation from Max Foundation for imatinib for now over a decade, and actually get the first line, but also they get the second line for those that need the second line. So these are one of the solutions that I believe should be pushed, especially in the global oncology community. Another is, of course, optimizing health system capacity to have their own review and adjustment to the medication prices. As I said, sometimes the negotiations between countries and pharmaceutical companies are one way, but I think we need to optimize the healthcare system so that we have our own capacity to review and also adjust the medication prices. And of course, implementing the differential pricing based on health system purchasing power, not putting everyone in the same basket as if we are going to be able to have the same capacity. And I highlighted this because it's very important. Increasing transparency around cancer medicine prices. As I said earlier, you can be two governments going to buy the same drugs and you get different quotation from the same company. So we need to have a very transparent system around cancer drug medicine, cancer drugs prices. Of course, governments that are planning to put cancer drugs or already put cancer drugs on their national formulary and are able to purchase or procure these drugs, I think it's essential that they can use some of the tools that we have already. For example, the ESMO magnitude of clinical benefit scales, or the NCCN guidelines and ASCO value framework. They can be used to guide governments to actually evaluate the benefit of the cancer drugs that are put on the national essential medicine list if they're going to be available, of course. And another thing to consider is pulling efforts from different stakeholders. That is the Ministry of Health, partners that are involved, of course, in cancer care in different countries, so that they can have one voice that is one, so that they can go and negotiate for the prices when they're a big group. For example, even countries that are in the same region procuring drugs at the same time, so that companies, of course, they're also making profit, so that they can also, if they're going as a block, sometimes I think it can be one way to negotiate reducing the prices. And of course, removing the incentives for prescribing cancer medicine that have limited clinical value. I think this should be stressed. There's no need of when government can not even afford the old traditional cytotoxic chemotherapy, and then you're prescribing drugs that are not beneficial to patient, and of course taking a lot of funding that should be allocated to other things. Last but not least, of course, is developing national models that are used to estimate the demand, cost, and drug procurement needs for the countries. Some of the countries actually fear having cancer drugs on their national formulary based on fear, without really modeling the needs and the cost of this cancer medicine. And I'll give an example of course, of Rwanda. Right now, as I said, we don't have cancer drugs on our national, we have them on our national essential medicine, but they are not covered because of some of time. The discussion we have had with policymakers is that they always say that cancer drugs are very expensive, but when you ask them like how expensive, sometimes they're not able to tell you that. So we held a 5-day workshop, and this workshop had where oncologists, pharmacists, nurses, program managers, and economists, and we wanted to actually cost cancer drugs based on the national cancer registry data that we had by then. And we use the National Cancer Protocol, which is modeled from the NCCN harmonized guidelines for Sub-Saharan Africa. And as I said, we use the National Cancer Registry data for 2019. The drug prices, we use different prices from different companies that procure drugs for Rwandans, especially for the one of the hospitals that provide cancer care for patients with the National Health Insurance Scheme. And we reference this to the WHO 2019 Essential Medicine List. And the costing was for the curative intent, and also first line, second line, and third line treatment for the most common cancers in Rwanda. So when we did this exercise, these are the cancer types that we looked at, and the numbers for 2019. As you can see, breast, cervix, prostate cancer, and stomach and liver are the most common cancers in Rwanda. And when we looked at this, I'm not going to probably go into the details of the whole exercise, but as you can see, the cost of cancer drugs for all the the drugs, not necessarily those that are on the WHO essential medicine list, both for curative and non-curative, we found that the total costs would be for the cancer drug, for the cancers of numbers of 2019, the total cost would have been 10 million USD. But when we looked only for those that were on WHO essential medicine list for the 2019, the cost dropped down to 8 million. But as you can see, the adult CML, the drug is, of course, imatinib here, was the driving for the high cost of cancer drugs. When we removed the imatinib, the cost dropped down to about 1.4 million USD. And this is for both the curative and the non-curative intent. And then we kept on monitoring this, and we looked at the cost for drugs for the top 10 cancers, curative and on all the drugs, not necessarily the essential medicine lists on WHO. And the prices actually even went further down to 4.4 million USD. But when we looked at the most top 10 cancers and curative purpose only and on the WHO essential medicine list, as you can see, the total price actually went down. So this exercise was to show the policymakers and the government that actually when you go into the details, cancer drugs are not that expensive, but we need to have priorities of which cancers that we are starting with and investing on. And of course, if we cover this, especially for the curative intent, for those that are, for the cancers that are very common in the country, then we can actually, put these drugs on our national formulary and make them available to our patients. So we presented this to the policymakers, and as we talk now, there's a discussion that actually the cancer drugs are going to be, put on covered by the national insurance scheme and made available for cancer patients. But of course, the advocacy continues with the data, and of course, with a lot of convincing to policymakers that the cancer patient need these drugs if we are to aim to treat our patients that are coming to us. As a final thought or conclusion, I would say that access to quality cancer medicine should be a global priority for all the stakeholders. And when I talk about the stakeholders here, I talk about the oncology community and all of you that are here. I think it should be our priority to actually advocate for availability of cancer drugs. Of course, healthcare policymakers, government administrators, pharmaceutical industry, and of course, patient and all the advocates. And with this, I'd like to thank you for your kind attention.
So thanks very much, Fidel, for that presentation. I think the thing that strikes me right off the top is, as you're concluding there, your ability to translate the scholarly work you've done into action and impact for the people of Rwanda, the cancer patients of Rwanda. That's incredible. So congratulations on that. Tying your research to action, that's amazing. We have some time for questions. We have quite a good group here. Any questions for Fidel?
Yeah, and also contribution to how we can actually, put efforts together, not only questions.
Yes.
Yeah. Hi, Fidel. Thanks for a great talk. You touched on this on one of your slides, but I do think that we as a community need to take some ownership for some of this problem. And there's probably a good reason why the policymakers and our colleagues in other areas of medicine roll their eyes and don't take us seriously when we ask for more funding for cancer medicines. And I mean, other specialties make fun of us. And there's a reason why sometimes they make fun of us. And that's because as a community for a long time, we've advocated for everything. including a bunch of very low value medicines. And so I do wonder if you think that we should be positioning the movement and value of care and choosing wisely as a way to ensure that the medicines which matter the most are actually available. Just was curious about your thoughts and whether that's a message that maybe we've been working on at the periphery, but haven't really explicitly driven that home. Just like to hear what you think about that.
No, I agree with you. And I think when we did the modeling, that was exactly what we wanted to show them, that when you say that cancer drugs are expensive, it's not really those that matter. Because when you look at it, actually, the old cytotoxic drugs are not that expensive. And most of our cancer we see, actually, we are still using these drugs and they're still beneficial to our patient. So I agree with you that we wrapped everything together and took the package to the policymakers, and they see all the billions because of the drugs that we're including, and they fear to actually cover this. So if we unpack and take a message clearly of the value of care, I think they will start understanding. I'll give an example. When we started treating cancers in Rwanda at Butaro Cancer Center, that is a decade ago, we had the same discussion. There were no really funds or resources to cover every patient. So all stakeholders that were involved took a bold decision and said, we're not going to be treating a metastatic disease because we don't have resources. But we can start with creative intent, especially for those that we know that have good survival benefits. And that's what we did for years. And as resources were available, we added advanced stages and other drugs that, say first, second line, third line for metastatic diseases. But when we started, because of the resources that we had, we didn't cover every disease. So I agree with you that I think we need to unpack the message and say there are things that are very important and there are things that we can do later on. But I think we need to start from somewhere.
Thanks. You're on mute, Scott.
Sorry, any other questions for Dr. Rubagumya? Well, if not, oh, sorry, Nazak, go ahead.
Thanks, Fidel. So that was great, although I missed some of it because I had to run and see a patient. But I was wondering, what are the possibilities of collaboration among African countries? You may have touched on that, but coming together, negotiating prices, the fact that there are different models of coverage in different countries, and also the other question is, do you see things getting better? I mean, we've seen like in Sudan and Ethiopia, there was universal health coverage for drugs like doxorubicin, cisplatin, but then the shortages, and sometimes the government not sending the money on time. So these all of these issues, and of course the private the drive for the, so as if we have two worlds. You go into the private clinics and you see regorafenib sometimes, or kind of these drugs given, while you walk into the public hospital and even doxorubicin is not there. So
yeah, no, I agree with you, and I touched a bit on that especially for countries that are in the same region. For example, if like Uganda, Kenya, Rwanda, Tanzania go and negotiate drug prices at the same time, not as individual countries, I think that would increase, the numbers, and probably would have negotiating power with pharmaceutical companies or whoever is selling the drugs. So going as a block, I think, is one way to work as countries in Sub-Saharan Africa. And as you said clearly, for example, when I started residency in Tanzania, the government was buying drugs, but there was a lot of stockouts. And what we did is, sometimes you could write a regimen, let's say, for example, ACT, and the patient goes to the pharmacy and they say, we don't have doxorubicin, but we have cyclophosphamide and taxane. And as a clinician, you're like, what will I do with a single cyclophosphamide for a patient with advanced disease? I mean, stage 3 or stage 2. So sometimes you find that you actually providing suboptimal drugs or regimen because of the issues of stockouts. So stockouts are very prevalent, and I think for me, block procurement as countries probably would increase the power, negotiating power for these countries, and also having models, because many countries, we don't even have well-functioning national cancer registry, and sometimes we don't know how many drugs we need for how many patients. So having well-functioning cancer registries and modeling, like forecasting the need, will also help government to know how much they're spending on cancer drugs.
Thanks, Nazak. Great question.
Thanks.
Anybody else? Nazak, do you have another question, or?
Well, just one, if there's no other question.
Mm-hmm.
Well, go ahead, yeah. And obviously, anybody else, put your hand up or come on screen. Happy to, or put a question in the chat, whatever you prefer.
I am also interested in these kind of competencies, which is, looking at how the drugs are procured, how it's, like these kind of research, and whether they should be an important component of teaching so I was recently teaching the fellows in Sudan, and some of them, maybe that when they graduate, they will get to know, but whatever's coming through the government, they didn't seem to know exactly how it got there and what's the Ministry of Health doing and what's not doing. And so I think for when you're preparing your program for Rwanda, or maybe in the next awarding meeting, maybe that should be sort of a course as to all of these. How do you navigate that? How do you know about it? And how do you study it, actually, the research part of it?
I agree with you, Nazik. When I took my MPH, I think I now put on the MPH hat sometimes, and I see from the policymakers' point of view. So when we are not told this in our training, sometimes actually there is a fight between the policymakers and clinicians, because for them, they look at the large, I would say, picture. For us, we are looking at the patient most of the time, especially when we don't have knowledge about all these details. So I think it's really important that we have interaction with policymakers during our training, and so that we know all these challenges ahead of time. Otherwise, when we thrown into the clinical services after training and we don't know all these details, sometimes they creates frictions between us and the policymakers. And even when you could be doing the proper advocacy for patients, sometimes you find you're not well equipped to actually advocate for patients. So I agree with you that I think this is something competency that we need to have during our training.
Yeah, thanks, Nazak and Fidel. I think it's a very important point. I think to Chris's point, things aren't going to change unless the next generation of oncologists understand the complex economic, ethical issues around this, and have the knowledge to navigate this, and, as you said, advocate for high-value cancer medications and dissuade people from using low-value cancer medications. We have a question from Allison Bierling. Thank you. Thanks for the great presentation. Do you see any role for local production of cancer medicines as a potential strategy to improve access?
Yeah, I definitely think so. We have seen countries that have done this, have local production of cancer drugs. For example, India is one of the countries, though they have not really solved all the access issues, but the local production of cancer drugs have improved access to these drugs. So, but again, it comes down to the resources, and so countries governments will tell you that they don't have resources actually to have these industry set up, and pharmaceutical companies will say there's no great purchasing power in this region, hence there's no need to put these plants or industry in this region. So this is the same discussion, but I believe having local production of cancer medicine would be very, very essential to improving access.
Sorry, thanks, Alison and Fidel. Great questions, great discussion. Any other questions for Dr. Rubagumya? If not, it's close to midnight in Rwanda, so I will thank you, Fidel. Great to see you. Thanks for an amazing talk. Thanks for your work in this, both the scholarly work and for your advocacy for the patients with cancer in Rwanda. And really looking forward to welcoming you back soon. But in the meantime, take care of yourself. Thank you so much.
Thanks, Scott, and thanks everyone. Have a good evening.